really happy to see all of you joining for this. I have no financial relationship to the program, so no conflict in that sense. Arrows are not working now. There we go. All right, it's catching up. So as far as learning objectives, what I hope that you'll take away from this, and I'll review this at the end too, is to look at least 5 different reactions that people commonly report when they've lost someone that they've cared for to suicide. And again, I'm very much of this general phrase of someone that you've cared for, meaning that it can be someone who is a neighbor of yours, a friend of yours. Again, if you're a teacher or a counselor or a social worker or a nurse, somebody that you provided behavioral health or healthcare services for, not just immediate family members. So we'll go through that. And then I wanted to specify what the key characteristics of complicated grief are, and then how to apply that in your practice. Now, this is that there is a certain form of grief, which we'll go into momentarily, that is more likely than not connected to losing someone who takes their own life, who kills themselves. And the reason that we go into this is because typical grief counseling is not of benefit to people who are suffering from complicated or what used to be called traumatic grief, and I'll go into that too. So the first step is we'll talk about typical reactions that people will often report. And then we'll talk about who are the people who really suffer from this, where they develop this long-standing, chronic, often disabling kind of reaction of complicated grief, and then learn how that connects to an evidence-based treatment specifically for complicated grief, so that you get a general idea, hopefully when you leave here, about for you, if you have lost someone, or for anyone that you're working with or connected to, any of your relationships, you'll be able to pick up and screen for people who have this kind of issue, and then know what kind of treatment is helpful, and basically some of the basic principles of that treatment. So just as a review, I wanted to give you some relatively recent information about who dies by suicide in New Mexico. And in 2017, and before I go into that, I always like to say that this is suicide as determined by the Office of the Medical Examiner. And so it's underreported. There are a lot of people who die and they've taken their own life, but there's insufficient documentation to have that entered on the death certificate. So our suicide statistics are misleadingly low, even though they're alarmingly high. Whites and American Indians have the highest rates in New Mexico. The suicide rate in recent years is 3.5 times that for men as for women. Now, this is people who kill themselves. The rate for making suicide attempts is reversed, more women than men. Now, a few years ago, this rate was much higher in the sense that the rate of men killing themselves was 5-7 times greater, sometimes 10 times greater, depending on the state and the area, for women. Unfortunately, women have become more violent in their suicide attempts, meaning that instead of using medications or substances or pills for overdose, they are more frequently using firearms or suffocation, hanging, or jumping from a high place. Those attempts are more likely to be lethal than overdose, as we'll also talk about. So one of the things that we'll spend some time looking at in other discussions is about whether or not a firearm is available and is being used. So here's some more recent statistics, 2019 statistics, which are really based on 2017 data and 2018 data. On the average, one person dies by suicide every 18 hours in the state. It's the 9th leading cause of death in New Mexico, the 2nd leading cause of death for 15 to 34 years of age. And nationally, at that point, we ranked 4th out of the 50 states for suicide. We don't want to be a high rank like that. You're also aware of, unfortunately, we've had many suicide clusters. A suicide cluster is when a number of individuals kill themselves within a narrow period of time. There may be some connection to each other, either by social media or by relationship. And it's also a relatively confined geographic area. We've had waves of suicide clusters and contagion in high school age, middle school age, and that's continuing to be a big issue nationally, but especially in New Mexico. I wanted to talk briefly about LGBTQ youth. And basically, you see all the risk factors in this slide. A lot of them are psychosocial. So LGBT youth were much more likely to have unstable housing, and were much more likely to be victims of sexual abuse, violence, and that relates to one other factor, which is really important. There is no particular greater risk for LGBTQ youth or gender fluid or queer youth if they're in a social environment that's accepting and supportive. Their risk is identical to people who don't have that status. So it's really important to look at this as not an impact of being gay. It's more that's a cell phone. Sorry about the interruption. So now I just got off screen. Let me get back. So now I can't see the presentation again.
Susan, can you unshare and reshare on the same slide?
Yeah, so all I see is myself as opposed to the whole screen. There we go. Sorry about that, folks. So what I was going to say was that it's a social cultural issue and a contextual issue, which also tells us that one of the most important things that we can do is prevent bullying and discrimination in the school settings. So I like to start with this, that suicides are preventable. And it's, again, a public health issue. The best way to prevent suicide is restricting access to lethal means, especially firearms, responsible media reporting, early identification and treatment, and training. Okay. So this poll I always like to cite too, is that it was a relatively recent poll in September of 2018, thousands and thousands of people all over the country. 94% believe that suicide can be prevented, and the same group said that they would take action to help someone who they knew, who was close to them, who was thinking about suicide. This is totally contrary to the myth that people don't care about suicide, People don't think it's preventable, it's that it's hopeless. So this is something we need to always take up with us. And then if we look at lethality, remember I spoke about that, 85 to 95% of attempts by loaded firearms are lethal. Look at this, only 2% in New Mexico were lethal if they related to poisoning or overdose, and only 1% for cutting. So again, that tells us if we want to prevent suicide, where we need to focus. So again, restricting access to lethal means works. Now, I can't show you the video at this time for a variety of reasons, but oops, here we go. What I wanted you to know is that when somebody suicides, there's a dissemination of that loss throughout. So we've all lost someone to suicide in one way or another. And so one of the things to think about is this graph, which is very graphic. Every 40 seconds, someone in the world dies by suicide, and it's probably even more frequently than that. Every 41 seconds, someone is left to make sense of it. So now I wanted to go into that first part that I told you about as far as what we want to attend to. And these are actual statements by a lot of people that I've connected to personally, as far as a provider, or my trainees have, and also things that are reported in the literature. And that you hear oftentimes, especially from parents of children or youth who take their own life. I should have seen it coming, and I should have done something to stop it. And then, how could they abandon me? Didn't I mean something to them? So there's a sense of, if I was important to them, how could they possibly abandon me, leave me? Yeah, I'd said or done things differently, they'd still be alive. Now, this is really important to think about younger children in the home. And one of the things I've done is create an agency for siblings who've lost an older sibling to suicide, because children in kindergarten age, preschool age, often blame themselves for everything that happens, or it's all their fault. It's part of what we call the egocentrism of childhood. So a lot of us still feel that, and especially as providers. Why did I know that they were at risk, but I might have said something or done something that I shouldn't have, or failed to do something that I should have done that could have prevented the suicide? Magical thinking that we could have stopped it. How could I have been so clueless? How could I be caught unawares? Why didn't they trust me and let me know what was going on? And this is especially true for any authority figure. This can be for parents, guardians, teachers, nurses, doctors, PAs, social workers, etc. Everybody blames and judges me for their death as if I'm the problem. Parents are agonizingly going through this. Why am I so guilty, feeling relieved that their suffering is over and my suffering is over? And a lot of us who work with chronically medically ill people will understand that as well, that there's a huge burden on the caregiver. And some people are feeling guilty that the suffering of that person and their own suffering is over. So now we're going to talk about different types of grief. And what we're going to be looking at is normal anticipatory, disenfranchised, and now what's called complicated grief. It has been in the past called prolonged grief or traumatic grief, and we'll talk about why it's named that way. So one thing that we need to look at is that normally grief is a lifelong process. One of the things when I have more time and I talk about grief in general is that there's a myth of closure. We're constantly, if someone is really close to us and we're really connected to that person, we continue to be reminded of them in wonderful ways, in difficult ways. So it's really important to think that an ongoing process that ebbs and flows is normal, not a time-limited one. Anticipatory grief is when a death is expected, but before it happens. That can be for people with terminal physical illness, but can also be with people suffering from severe mental illness, depression, bipolar disorder, with numerous self-injury attempts and suicide attempts, where we anticipate that this might happen, or with somebody who's not suicidal at all, but is at risk for killing themselves, like somebody who is significantly dependent on opioids and might accidentally overdose and die. Now, disenfranchised grief is something that I really want you to think about. It's often missed. Disenfranchised grief is when we lose someone that society at large discounts or trivializes or minimizes. What does that mean? So not so long ago, if you were in an LGBTQ relationship and your partner, your spouse, the person who is very important to you died, your relationship was not recognized. And sometimes it was secret, except for you and your partner. So when you were deeply grieving, no one acknowledged it and you couldn't share it. Also, when we lose a pet or a neighbor or a teacher or anyone else who's not part of our biological, nuclear, immediate family, society at large may discount it or trivialize it and say, oh, they were just a pet. How can you be grief-stricken so much? One thing that I've seen a lot of it is for women who have a miscarriage or an abortion. There's a great social taboo about recognizing that as a loss, even from other women, sometimes because of the pain of it or because of beliefs about abortion. So there's many ways in which this is a factor, and oftentimes grief, which is disenfranchised, can lead to complicated grief because of the lack of social support, recognition, and you have no one to tell your story of grief to. So complicated, prolonged grief was briefly named traumatic grief. It was renamed because of confusion with traumatic bereavement, which is a loss due to violent causes and post-traumatic stress disorder. It's something very different. So let me put it another way. A number of people suffer from complicated grief because the loss of the person was traumatic. They died by self-inflicted gunshot. They discovered the body of the deceased. That's a catastrophic stressor that could trigger post-traumatic stress disorder or acute stress disorder. But that's a much narrower way of looking at people who suffer on an ongoing basis, where the grief is prolonged and complicated and not through this normal kind of process. One more thing about the normal, I always like to say this, is that as society at large, and sometimes in our professions, we're taught about the stages of grief from Kubler-Ross. There's absolutely no evidence, none, that that's really applicable. Kubler-Ross herself initially studied a few dozen people who were terminally ill. And this documentation that she created was a synthesis of their reactions to their own lives ending, not studying grievers, people who had lost someone else who had died. She also didn't initially look at it as a linear process. So I want you to do your best job about helping the people that you see not think of grief as a linear process with an ending point, like I said earlier. There's that myth about closure, and that you need to process things in a stepwise way. Otherwise, there's something deeply troubling about the way that you're handling things. One more category that I think is really important is what's called ambiguous loss. Now, what does that mean? That means somebody who's physically absent but psychologically present. So, children who are missing. Now, we can lose children to homelessness, substance abuse, people who are kidnapped, soldiers who die at war, or we didn't see them. But more troubling for a lot of people is psychologically but physically present. So when someone that we care for has a severe psychotic disorder and is not themselves, or a cognitive disorder like delirium and dementia, we lose that sense of their personhood. And so all we see is that body, but we don't see that person anymore. That kind of loss is very, very difficult to handle because it is ambiguous and confusing. A very close friend who, her husband of many, many years, 7 years ago, had a major stroke, which resulted in a significant cognitive decline and a change that was marked in the personality. He unfortunately died recently, and she easily says, I really lost him 7 years ago, and I've been grieving ever since. So ambiguous loss defies resolution. We're involved in this idea that we should be able to resolve this, again, have closure on grief. Ambiguous loss ends that. And as I've said earlier, grief is embedded within a context. This is a big belief of mine as a family systems person, and hopefully being culturally competent, that we always need to look not just within somebody's psyche, the psychological factors, we need to look at the social, cultural, spiritual, historical, political context of all this grief. So there's a complex interplay between all these contextual variables. So for instance, separate from grief now, there's been a lot written about people who now are worried about being deported, who already were concerned about strangers and to some degree home sheltering, and now with the pandemic have this double edge of anxiety and fear related to the home sheltering. Now, this is very important, and it may be relatively surprising to a lot of you, but the typical grief interventions that are often used, which again often talk about the grief work of Worden and the stages of grief of Kubler-Ross, there's little evidence that they're actually beneficial in normal grief. Now, why would that be? The issue is that most people who are grieving normally are highly resilient. And so if they don't want to talk about it for a time, it's because their coping mechanisms say, I don't need to ruminate about it. I don't need to process it. A lot of people have a way of looking at this based on having secure attachments before the grief happened, possibly ambivalent relationship to the person that they lost, but certainly overall a reasonable understanding of that relationship and a real understanding of why that person passed away, so that it has little or no positive effect for normal grief. For complicated grief, it can often be really harmful. Why? Because, again, if you have this idea of a stepwise phenomenon and a time-limited phenomenon, and people continue to talk about this, then it's, again, problematic. It's almost like converting someone to another religion that doesn't suit them, or the kinds of therapies that had been used in the past for LGBTQ individuals of converting them to heterosexuality. So who needs grief counseling? It's actually the people who are at the highest level of distress, are least adaptive, meaning that they're generally pessimistic before this ever happened. They had diminished social support, and this is important, don't find mourning rituals comforting or helpful. I put in bold, for today's discussion, they're more likely to have lost a loved one through suicide or homicide, a violent means. And maybe not so paradoxically, they're often the ones who most often seek grief counseling. So that goes back to what I said a while earlier, is that that's why it's really important to look at who develops what we've now called complicated grief, and the kind of treatment, other than the typical kind of grief counseling that's often used, that has been proven to be of great benefit to those particular individuals. And this is just one of the many studies that complicated grief shows that in randomized controlled trials, looking at this targeted psychotherapy, and we'll talk about what it actually does, along with strategies for looking at two aspects: accepting the loss and moving on, and then, really key, restoring a sense of possibility and future happiness. Those two general categories are really, really important in dealing with this. There's also, as you'll see in complicated grief, aspects of dealing with trauma and re-experiencing trauma. And we're also going to talk shortly about how to differentiate complicated grief from major depressive disorder and complicated grief from post-traumatic stress disorder. So the criteria for this is unusually severe and prolonged grief that significantly impairs function. It's more likely after the loss of a child or a life partner, after a sudden death by violent means, homicide and suicide, after discovering the body of the deceased. These are all traumatic factors. If high levels of pre-loss, insecure attachment, like I mentioned earlier, and dependency, and just as a review, I'm sure most of you know this, that there are basically a number of categories of insecure attachment. One of them is clingy and dependent. One of them is avoidant. Another one is disorganized, where you vacillate between these different ways of being, whether cutting people off or being overly dependent for your self-worth on the connection to the other person and how they view you. If you have any of those three categories of insecure attachment before the loss, then it's a setup for you developing this kind of prolonged, traumatic, complicated grief. And of course, like anything else, unfortunately, if you have other problems before this event, you're much likelier, unfortunately, to have a more problematic course. This is true for anything in physical health. Like we know, if you have severe lung problems, and now we're finding out cardiovascular risk or renal risk, kidney disease pre-existing, then you'll suffer more from being infected by COVID-19. So the clinical features are acute grief symptoms that persist for more than 6 months following the death of a loved one. And again, a loved one can be a student that you taught, a client that you provided therapy for, a dear neighbor, somebody that you ran into the neighborhood when you were walking your dog that you miss greatly and you enjoyed the conversations. It doesn't have to be somebody who is intimately involved with you. So you have feelings of intense yearning and longing for that person, missing the person so much it's hard to care about anything else. That's the focus of your life. And you can have preoccupying memories, thoughts, or images of the deceased that may be wanted or unwanted, that interfere with your ability to engage in relationships with others. You may seek proximity to the dead person through pictures, keepsakes, possessions, and other items associated with the loved one. So this is one of the major distinctions, by the way, that we'll talk about that relates to differentiating from depression and from post-traumatic stress disorder, because people who suffer from complicated grief are preoccupied not just by negative feelings, but also by positive feelings, missing the good qualities that that person brought, their vivacity, their creativity, their good humor, their warm presence. So unlike depression, where everything is gloomy, or for trauma, where everything is stressful and provokes anxiety and fear and panic, sometimes you'll yearn for that person in positive ways and feel that no other relationship could take its place in a good way for you. So you have recurrent painful emotions related to death. Again, those negative feelings of deep, relentless sadness, guilt, like we talked about. Why didn't I know of this? Why didn't I say something or do something differently? Anger, bitterness. How could they possibly leave me? Wasn't I important enough to them? All these feelings are difficult to control. Avoidance of situations, people, or places that trigger painful informations and emotions. So that could be, you don't want to go to your favorite restaurant. You can't listen to the music that you shared. You don't want to be in the hospital room in which they died. You avoid all the situations that remind you of the loss. And at the same time, you can have preoccupying thoughts related to their death. And this is really important. You have great difficulty restoring the capacity for positive emotions through a sense of purpose in life. I have nothing to live for is something that a lot of people who lose somebody important to them say to themselves. So if we look at complicated grief, depression, and PTSD, there have been many studies, especially in elderly grievers, because statistically, people who are older lose more people because people die of old age and they've had more life experience. So this is really important. Only 7.4% of people who grieved had complicated grief. where 16 to 24%, almost a quarter, suffered from major depression, and as much as a third from PTSD. So you can see that in this category, if we're looking at long-term complications from people who are on the continuum of normal grief, complicated grief, major depression, or PTSD, the smallest group is complicated grief, but they suffer greatly. This is important, again, clinically, because the treatment for major depression is different than complicated grief. The treatment for PTSD alone is different than complicated grief. So let's look at this more closely. What I have in bold in this slide is what relates to complicated grief and how it compares to depression. And you'll see common themes throughout. The sadness is related specifically to missing the deceased versus a pervasive sense of sadness. There's interest in memories of the deceased, longing and yearning for contact, and even pleasurable reveries, pleasurable thoughts, letting yourself daydream about all the wonderful times that you shared together. With depression, there's a lack of interest, even in self-care. The guilt, if you experience it, is focused again specifically on interactions with the deceased in complicated grief, again pervasive. So you see all along here, everything is specific to the loss of that particular person, as opposed to being pervasive. Unlike depression, there's also a preoccupation with positive thoughts, where depression, any kind of preoccupation and rumination that that person has is about failure, misdeeds, problems, negativity. You can have intrusive images of the person dying and reminders of the loss. This is not prominent in major depression, where complicated grief does not exist. Now, let's do the same comparison with PTSD. So if we look at that, we find that the grief is triggered by that loss versus a typical catastrophic stressor of physical threat or trauma. The primary emotion in complicated grief, if it's problematic, is sadness. The prominent one in PTSD is worry, anxiety, fear, panic on that continuum. Nightmares are extraordinarily rare in complicated grief, very common, like you all know, in PTSD. Painful reminders are more pervasive and unexpected in complicated grief. Everything can remind you of that person versus the specific precipitants with the traumatic event that relate to re-experiencing. And then again, there's a yearning and longing for the deceased and that pleasurable memories and reveries and going back into that space of connection with the person that you've lost that are not prominent at all in PTSD. So hopefully you see that both in comparison to PTSD and in comparison to depression, everything that the person suffers in complicated grief is specifically directly related to that loss, and that the feeling is not just dysphoric or uncomfortable emotions, it's also positive, pleasurable emotions and ruminations and thoughts. So again, I wanted to emphasize why it's important to diagnose because of this evidence-based treatment that I'm now going to go into. So why complicated grief treatment? People with complicated grief experience loss-focused attention that's intensely painful, while their restoration-focused attention is associated with a sense of disbelief and protest. In other words, I can't possibly recover from this. How can I find any joy or meaning in life after this terrible thing has happened to me and to this person that I love? In complicated grief treatment, the bereaved performs exercises inside and outside of the session to come to terms with the loss-related activities, and address restoration of the capacity for joy and satisfaction in life. And as we talk about a lot in suicide prevention, recovery is not the loss of symptoms. This is true of recovery from physical illness, from substance abuse, right? From self-harmful kinds of feelings and self-injurious kinds of feelings. Recovery is a restoration of purpose, of meaning, of reconnecting to what makes life worth living. So complicated grief treatment calls on interpersonal therapy, cognitive behavioral treatment for PTSD, motivational interviewing, and some other formats. And again, restoration-related activities continue in parallel with loss-focused interventions. One of the things, too, that I should say about most grief therapies for, quote, normal grief, is that they focus solely on loss-focused kinds of interventions, not on restoration. So I'll briefly let you see this format, but the important thing is, like any therapy, you do your assessment. That's the first stage. You establish an alliance. You give a lot of information, like I'm giving to you now, about the difference between, quote, normal grief and prolonged, complicated grief, how they're different, how it relates to that particular person. And then the meat of it is in the middle section, which is longer than the first and the last. And that's coming to terms with loss, addressing restoration of capacity for joy and satisfaction, as we keep on emphasizing. So the targets are this. Most bereaved balance grief-related thoughts, separation anxiety, protest, sadness, self-blame, with greater acceptance and optimism for the new reality. Most bereaved. Those with complicated grief can't find a balance. People with complicated grief often excessively avoid painful situations or compulsively seek proximity with and dependency on other people. People with complicated grief experience loss-focused attention that's intensely painful, infused with deep longing, while their restoration-focused attention is associated with a sense of disbelief and protest. They're almost ashamed. How can I possibly be feeling good or looking forward to connecting to someone or taking pleasure in this meal or in with a friend when I lost this person, much less that they killed themselves in front of me? How am I even remotely entitled to feel good again? So the framework is that psychoeducational piece, information about grief, complicated grief treatment, use of a grief monitoring diary. And this is something that I feel is very important. Often the involvement of the significant other. I really always favor therapies that involve, like with youth, their peers that they select, but reaching out into their natural support so that they're always aware that there are people on their side besides the therapist that, quote, has to see them or is paid to see them, so that they know that there is natural support in their community of others. Facilitation of optimal interpersonal functioning, working on personal goals and self-care, revisiting the story of death, its implications and consequences, working with memories, pictures, other mementos, an imaginal conversation, and then looking at the psychological impediments to the grief process, identifying that for them, targeting that, including thoughts, feelings, and behaviors that activate the attachment system or impede its deactivation. So the grief monitoring diary is daily ratings of the person's highest and lowest levels. This is not a highly structured format. This is someone that they co-create, something that they co-create. And it's very much on the journaling therapy of Pennebaker, which those of you who might remember, just journaling in an open-ended way about a difficult situation on a daily basis, sort of establishing a ritual for journaling, as little as 20 to 30 minutes a day, itself is helpful. Helping people who are bereaved recognize situations that are associated with high levels and low levels of grief, so they see, oh, there's something in the context that makes me feel this way. It's just not happening out of the blue. That gives them a better sense of self-control. It's also a way of monitoring progress. If we're looking at imaginal revisiting, that's the person verbally talking about the story of death. And it's a facilitated kind of exercise. So we talk about preparation, coaching, talking about this in the therapy, and then this is really important, extensive debriefing of the revisiting exercise with a focus on identifying the problematic beliefs that are sticking points. And the bereaved person is both the reporter and the observer in retelling the story of the death. There's also a visual exercise at the end of the debriefing to help the person imagine how they might put the story away. Situational revisiting is, for those of you who know about behavioral therapy, it's graded exposure therapy. So this is a planned, intentional revisiting of things that you avoid, like going out with friends that were mutual to you and the person that you lost, going to restaurants that the bereaved like to frequent, reliving those things experientially. So you talk about it, you envision it, you taper into it. And one thing that a lot of people have difficulty with is disposing of personal items, visiting the hospital where they died, spending times in the rooms where people live, listening to their favorite music, etc. So this is the typical format of graded desensitization hierarchy, where you go into this bit by bit by bit by bit until you're able to re-experience those kinds of events and places and situations, so you're not paralyzed by fear, panic, and avoidance. You have an imaginal conversation between the griever and the deceased to talk about your ambivalence. In all of our relationships, we can have gloriously wonderful things, but there's something that we did that irritated us with that other person, and some aspects of them that we found very frustrating. It's important to talk about both. And again, like that previous exercise, you first relax, then you have a graded, gradual, soft entry. You actually have the conversation, you close down the conversation, and then an extensive debriefing. It's really important to follow this structure so that the person is gradually more and more comfortable with talking about it. And as the therapist, you look at all the cues about what they're able to do and what not. Don't press too much, but don't let go so easily. So these are the loss-related activities. Again, imaginal revisiting and debriefing, situational revisiting and debriefing, imaginal conversation, working with memories, pictures, mementos. Then if we're looking at restoration-related activity, we're looking at personal goals by motivational interviewing, looking at values, looking at decisional balance. What are the benefits of moving in this direction? What are the barriers and the challenges? Re-envisioning the future by identifying practical long-term goals that create a sense of interest, excitement, possibility. And then you invite the bereaved to consider what she or he would want to do, or they, if grief was at a level where it no longer interfered with their life. This is a little bit of solution focus though. So if you imagine a place where you're no longer paralyzed by this complicated grief, what would you want to do differently? What would you hope for? The restoration is enhancing self-care, involvement of a significant other, a peer, a friend, a relative, optimizing relational functioning, which is supporting the bereaved's current close relationships, including pleasurable and satisfying social relationships, and problem solving any kind of issues with relationships to move them forward. Now we've gone through the overall framework of complicated grief treatment, and I want to end before we have the question and answer part with the importance of installation of hope. And I love, this Emily Dickinson poem. Hope is the thing with feathers that perches in the soul and sings the tune without the words and never stops at all. So hopefully you've gotten some idea of typical reactions of people who lose someone that you care for to suicide. You've been able to look at the different aspects of complicated grief and how it contrasts with depression, major depressive disorder, and post-traumatic stress disorder. Look at the guiding principles of complicated grief, loss activities, restoration activities, and looking at how this is drawn, and then the specific techniques. And now in these references, I give you all the evidence for what I'm talking about, a lot more information about complicated grief, a lot more information about complicated grief treatment, and Bonanno's work, which is about how normal grief therapy isn't always all that helpful for people, either with normal grief or certainly people with complicated grief.